Today we are discussing the case study of Daniel Smith, name changed, who is a 6-month-old male presenting today here at the office with his father, Bobby, for a plan of care discussion. At 3 months old, Daniel was brought in by the PCP and sent to genetics for a HXA blood test after she had suspicion of GM2 gangliosidosis. So it came back positive, and now they are here to discuss further options. The patient was born at 39 weeks, uncomplicated birth. No pertinent family history or surgical history up until this point. However, a pertinent social history. The mother was in a fatal MVC when the patient was just under 3 months old. The father has very little family support as he left the church, and his family is are Ashkenazi Jews. Um, as for the patient presenting today at my visit, um, he was feverish at 102, was hypoxic at 88%. He was dyspneic at rest with costal retractions as well as nasal flaring. Some other noted symptoms that the patient was displaying was lack of smiling. He is no longer crawling or turning over. The father said he no longer follows items or people with his eyes, has had low muscle tone, has had two tonic-clonic seizures, has signs of aspiration with bottles as well as a decreased appetite. So today we discussed our options going forward. So our options going forward is not withdrawing care, and instead it is foregoing invasive and aggressive treatments in order to provide comfort for the patient in their last days. Um, as for who would be the patient's proxy, it is the father. The father, when having the discussion about the plan of care, was responded with feeling overwhelmed about the severity of the disease and lack of treatment. Um, we did discuss some barriers, which would be the lack of family support on the dad's side, as well as being a single father now. He also was struggling with his own beliefs of ideas of the afterlife, which made the decision to withdraw care, or I should say, change interventions even more difficult, just because he did not have a clear understanding of what would happen after the child's death. The dad is the healthcare power of decision. Um, some goals that we discussed with the dad is to treat the pneumonia that the patient is presenting with today. We wanted to reduce the occurrences of seizures. We did go ahead and do a home hospice referral, as the dad's goal for the patient is to prevent hospitalizations and optimize pain and comfort care. So we already discussed the interventions. Genetics just had a discussion with them as for prevention of progression of the disease, such as enzyme replacement therapy, enhancing therapy, bone marrow transplant, or substrate reduction and gene therapy are not an option for this patient. However, we are going to do anticonvulsants. We are going to do chest physiotherapy. We are going to do a respiratory vest in order to provide physiotherapy to help treat the pneumonia. We are going to do IV antibiotics at home. We did have educational points that we discussed about taking precautions that if the baby is eating, that we position them well to prevent aspirations. We did discuss the father did want to do IV fluid resuscitation as tolerated. So we did have the discussion that if the patient starts displaying signs of aspirations, that we would discontinue it. We talked about um, the CPR. So for life-sustaining treatment, he does not want CPR. He wants the patient's code status to be changed to DNR with no interventions for cardiac arrest. No intubation. However, the father did discuss being open to use of nasal cannula for the patient, but no non-rebreathers. The dad does not want any dialysis or blood transfusions. For artificial nutrition, we did discuss um, placing an NG tube as tolerated, but he does not want to do any surgical peg insertion or any surgical interventions at all. I did make the point that the patient is dying of the disease and not from a lack of nutrition. For the IV treatment, we are doing IV Keppra, 30 milligrams per kilogram per day in twice a day dosing. For the antibiotic treatment, we are doing empiric coverage with vancomycin, 50 milligrams per kilogram per day, 3 times a day. The father does not want any hospitalizations. We are going to do IV at-home treatments as well as having a home hospice. For diagnostic testing, no invasive testing. However, he is open to doing chest x-rays for evaluation of the progression of pneumonia. We talked about the medications that we would use, the PRN medications to manage symptoms such as tachycardia, secretions with Robenal, and pain and dyspnea with morphine. We did not want to do any cardiac defibrillators, and the patient did not have capacity as he is 6 months old, so dad is the healthcare proxy. Some educational considerations for end of life. For Tay-Sachs, we did discuss the baby having a decreased appetite, and instead of trying to feed them, which they may not tolerate, instead doing mouth swabs or moisturizers for dry mucosa and lips. The patient will also have decreased alertness and eventual progression to a vegetative state potentially. So we did discuss that he can still interact with the child, and the patient may respond to stimulus such as the father's voice or music. Noisy breathing as well as respiratory symptoms may be present as changes in breathing such as slow breathing, fast breathing, periods of apnea. We may control with morphine. However, that will continue to progress as the end of life progresses. There may be some cardiac insufficiency, which would show as an irregular heart rate and weak pulses. And we provide reassurance that it is not uncomfortable for the child and is just a progression of the disease. We made a point in discussion that the goals in care is to provide comfort medications, but not to hasten death, and it's really just to prevent suffering. At the end of this visit, the father was appreciative and had a better understanding of what to expect as the disease progresses, and had a better understanding of the goals of care that he had for the end of life for his child.